Okay, welcome to this deep dive. Today, we're really getting into a specific piece of source material, an admission protocol for patients coming in for emergency surgery. And this one is specifically tied to the work of vascular surgeon, Dr. Gregory Weir.
Right. And for you, perhaps a registered nurse or a clinician stepping into these, well, high stakes situations, our mission today is really to walk through this protocol step by step. We want to pull out the absolute essential actions and, the why behind them from this document, make it clear.
Exactly. Because in the, let's face it, the chaos and speed of an emergency setting, having crystal clear documented procedures like this, well, it isn't just a nice to have, it's fundamentally essential for getting safe, efficient care moving for that patient. So let's unpack this roadmap.
Okay, so this protocol gets right down to business, starting the moment the patient actually arrives on the ward or in the unit. The very first step, patient identity verification. You absolutely need to confirm who they are.
How do they specify doing that?
Using the hospital sticker, getting verbal confirmation directly from the patient, and crucially involving the family if they're present to sort of double check.
Hmm. And wrapped around that vital ID step is something else important, a human element. Welcoming the patient and their family, making it clear you are there to help the patient, as urgently as possible. That must set a compassionate tone immediately.
It really does, especially in what's likely a scary situation for them. Okay, moving swiftly, the protocol details the stat blood tests, the ones needed right away. This is where the clinical action really kicks off based on that urgency.
Right, so you're immediately looking at ordering tests for urea, creatinine, and electrolytes. The UK panel, that's standard baseline stuff.
Correct. And then specifically troponin T and myoglobin.
Ah, okay. Why those specifically in this context?
Well, in potential vascular emergencies, these markers are pretty critical for assessing any underlying cardiac strain or even muscle damage, things that could complicate surgery or maybe indicate the extent of the ischemia.
Got it. Followed by a full blood count just to get that rapid snapshot of blood components.
Yep. And a coagulation profile, checking INR and PTT. Understanding the patient's clotting ability is, well, absolutely vital before any emergency surgical procedure. Can't stress that enough.
No, absolutely. Now, under other investigations, there's a very specific instruction, isn't there?
Yes, tests like a chest x-ray, duplex Doppler ultrasound, MRA or CTA, magnetic resonance angiography or computed tomography angiography. These should only be performed if explicitly requested by Dr. Weir.
And the thinking there is to prevent delays,
Yeah.
right? Ensure only necessary imaging is pursued when time is critical.
Exactly. It keeps things focused.
Okay, so once those initial steps are in motion, the protocol immediately transitions into patient preparation for surgery. This has several, non-negotiable actions. First off, the patient must remain nil per mouth. Nothing by mouth from the moment they arrive until surgery.
Standard pre-op, yeah. And respiratory support is key for optimizing oxygenation before anesthesia. So apply an oxygen mask delivering 40% oxygen, flow rate more than 5 liters per minute.
And frequent vital signs assessment is mandated every 15 minutes. That's pretty intensive.
It has to be. You're monitoring blood pressure, heart rate, respiratory rate, oxygen saturation by pulse oximetry, and temperature, continuously tracking.
Okay, this next instruction seems critical, especially for vascular patients.
Yes, absolutely. Do not apply a blood pressure cuff or attempt to draw blood from a vein on the affected limb.
Why is that so crucial?
Well, think about acute limb ischemia. You need to preserve any collateral circulation. Or perhaps a limb is being prepped for some delicate grafting. You just have to protect that limb from any potential compromise, any hematoma.
That makes perfect sense.
Okay.
Then you move into the preoperative assessment itself, which includes getting a preoperative electrocardiogram,
Yeah.
an ECG.
Uh-huh. And simultaneously, insert an intravenous line and start standard intravenous fluids. That's 0.9% sodium chloride. The rate is specified too. 80 milliliters per hour, bumping up to 100 milliliters per hour if the patient weighs over 100 kilograms.
Right, and then there's the assessment piece, allergies.
Essential. Thoroughly assess and document any patient allergies, especially things like iodine or specific antibiotics you need to know. And you also need to meticulously assess and document their current medication, paying extremely close attention to any blood thinners, anticoagulants, antiplatelets. That's critical information.
Yes, and the protocol is really clear here. Administer all urgent and preoperative pain relief and other medication immediately as prescribed. Speed is paramount.
Managing pain, optimizing their status quickly, absolutely.
What about blood transfusions?
Good question. The protocol actually states you should only order blood products if specifically requested by Dr. Weir. It gives an example like an aorta aneurysm rupture where you might anticipate needing blood immediately, but otherwise, wait for the specific request.
Okay. And to keep the patient stable, minimize demand. Strict bed rest is required.
Correct. And also, the practical things. Ask the patient to remove items like dentures, jewelry, contact lenses before they head to the operating theater.
Makes sense. And if there's time, which, in an emergency might be tight.
Right. If time allows, the protocol requests giving the patient a sponge bath using chlorhexidine soap for infection prevention.
Naturally, provide the patient with the correct operating theater attire. And then we get to the critical consent steps.
Yes. Request the patient or a family member to complete the pre-anesthetic form, and request the patient specifically sign the hospital permission form with a family member signing as a witness.
Okay, almost there. Before transfer.
Final check. Double check the planned procedure and, crucially, the body site where it will be done. You compare it with the patient, their family, and the operating theater list. It's about preventing any errors. That last safety net.
Okay, final section. Transfer to the operating theater.
Right. The family are encouraged to accompany the patient to the entrance of the theater complex if they wish. A bit of support.
And the protocol notes the procedure will likely be in operating theater 15.
Yes, and post-procedure, the patient will typically be transferred to the cardiac high care unit or the intensive care unit for that close monitoring afterwards.
Where can family wait?
They're welcome to wait in the designated waiting area near the theater complex. Dr. Weir will communicate with them directly after the procedure's finished.
Now, you mentioned this isn't just a standalone checklist.
Exactly. What's important to note is that this admission protocol, it explicitly references a continuum of care. It's part of a bigger picture. It directs you, the clinician, to refer to the general postoperative protocol and the blood pressure monitoring protocol, which logically follow on from this admission phase.
Okay. And it also states that a procedure-specific postoperative protocol, tailored to the patient's particular surgery, will be attached to their postoperative prescription chart.
That's right. And finally, looking towards discharge, a specific discharge protocol and the plan for home medication will be given directly to the patient when they're ready to go home.
So pulling this all together, following a structured protocol like this one in emergency surgery admissions, it sounds like a lifeline, really.
It is. It's clearly designed as a step-by-step roadmap. Its purpose is to ensure patient safety and highly efficient care. It guides clinicians through those critical, time-sensitive actions with, hopefully, minimal delay.
Absolutely. It lays out that critical pathway right from the start. Okay, here's a final thought for you, the listener, to consider. How do these clear documented protocols, like this specific one we've walked through, how do they impact team coordination and overall patient outcomes during those incredibly high-pressure emergency situations? Think about the precision and, importantly, the shared understanding they create amongst the entire team, something to mull over.